Welcome to Reducing the Pucker Factor podcast, presented by the Blakery Content, the show to make every EMS and critical care provider feel sharper, calmer, and more prepared when the pressure is high and the patient is small. Here, we're going to dive into real conversations that matter: pediatric readiness, high stakes, decision-making, pre-hospital innovation, and the human side of caring for kids and families in their most vulnerable moments. From the scene to the sky, from the med unit to the helicopter, this is where EMS meets clarity, confidence, and community. Whether you're an EMT, paramedic, nurse, or flight clinician, our mission is simple: reduce the pucker factor. One practical insight, one expert guest, and one powerful story at a time. But before we get started, a quick reminder: the content in this podcast is for educational purpose only. Always follow your local protocols, policies, and procedures, and practice within the scope allowed by your state and your medical direction. Every system is different, every patient is unique, and your agency's guidelines always take priority. Now, take a deep breath. Let's get ready to turn that chaos into confidence. This is Reducing the Pucker Factor podcast. Let's get into it.
For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. For the ones who are running faster, we're reducing the pucker factor. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the Blakery content crew, leading what the pros now do. Turn the fear into calm under pressure. Pucker factor, gone forever.
All right, so welcome back to Reducing the Pucker Factor, the podcast where we take high stakes medicine, high anxiety moments, and high pressure decisions, and we turn down the noise so we can think clearly. I'm Christopher with the Blakery Content, and whether you're in an ambulance, a helicopter, or in the ER, or listening as a parent trying to make sense of pediatric health in 2026, this is where we bring clarity to the chaos. Now, there are physicians who practice quietly inside clinic walls, and there are physicians who step into the arena. Today's guest is doing both. So, Dr. Tracy Tyson, she's a board certified pediatrician practicing in Vermont, but her exam room doesn't end at the clinic door. It extends into millions of scrolling thumbs, late-night parental anxiety spirals, and the algorithm-driven chaos of modern health information. Because in 2026, pediatric medicine doesn't just happen in exam rooms. It happens online in a world where pediatric advice competes with conspiracy threads, influencer hacks, and my friend said, medicine. She shows up with something radical: evidence, calmness, clarity. So today we're kind of bridging that gap, and we're going to dive into the most common pediatric conditions that send families to the emergency department. We're breaking down some of those diagnoses and what they actually mean, and more importantly, what symptoms should truly concern parents and providers. And we're talking about family-centered care in pediatrics, how we communicate, how we reassure, and how we partner with families when their child is the patient. So, Dr. Tracy Tyson, welcome to Reducing the Pucker Factor, and thank you so much for being here today.
Thank you so much for having me.
Absolutely. I've been looking forward to this. As you know, I've been following you for quite a while and just love the information and content that you're putting out. And if you're okay with it, we'll kind of start into this with somewhat of a little bit of a rapid fire and just run through a few questions here, 5 or 6 questions, whatever comes to your mind, 1 to 2 word, maybe a sentence. But and if you want, we can circle back and dive into any of those deeper if you'd like. But if you're ready, we'll get started.
Let's go.
All right. So what would you say is the most dangerous assumption about pediatrics?
That they are little adults.
Yes. The symptom that makes you lean forward in your chair immediately.
Noisy breathing.
Okay. And what would you say is the most overused intervention in pediatric respiratory illness?
Antibiotics.
Yeah. What is one phrase that you say in clinic almost every day to calm the family?
Call me back if anything changes.
Okay. One thing EMS providers should know about primary care follow-up.
That we don't always have the ability to do some of the things they think we do.
Yeah. And last one here, pediatrics in 2026, safer or more complicated?
More complicated.
Yep, I agree. Do you want to circle back on any of those, or you want to continue down.
I mean, I could talk about all of them all day. So you just keep
Right.
going and I'm sure it'll
Okay.
go.
Yep. No, I love that because, what you just highlighted, those dangerous assumptions, those red flag symptoms, those overused respiratory interventions, right? And even in the complexity of pediatrics in 2026, that all kind of speaks to something bigger, and it speaks to those patterns, and it speaks to what parents are seeing at home and what ultimately pushes them to seek emergency care. So let's zoom out a little bit. And from your vantage point in primary care, then, what are those most common pediatric conditions that send families to the emergency department? And not the zebras, not those rare
Mhm.
catastrophes, but those everyday illnesses that kind of sit in that gray zone between reassurance and escalation. And for EMS providers, ER providers, and parents that are listening and understanding what's common is how we reduce some of that unnecessary fear and recognize when something truly isn't okay.
Sure. I think the most common thing that we see parents going to the emergency room for would be fever. I think there's still quite a bit of misunderstanding as to fever and how to treat it, when to treat it, what a child looks like when they have a fever, because they can look extremely ill when that temperature is elevated. And so I do find that there's still some fever phobia. And so that's probably the one that I see the most as like when I see those calls the next morning is that it's fever. The other one I notice is, again, kind of back to that noisy breathing. While that can be a really concerning symptom, it also can be just part of having an upper respiratory infection. And it's really hard for parents to tell the difference. It's hard for us as medical providers to tell the difference sometimes. So I find that that one is another big one. And then I think the third one that I see the most is around a child not eating or drinking. That is a really distressing thing for a parent. I think we spend those first few months like focusing so much on exactly how much they're eating and how often and how much they're urinating and that when they don't do those things when they're sick, that tends to be something that causes the most panic for parents.
Yeah, absolutely. Those and I always encourage providers to talk to the families because those families, like you said, like they are tracking all of that stuff. Like they are very familiar, so they're going to pick up on those subtle differences, those subtle changes. Where when we show up, we're like, "Yeah, that seems normal or okay," but for that child, that may be a drastic difference. So incorporating them in there. So let's dive into some of those, right? So when we talk about fever, what are some of the main things that come to your mind, and what are things that are acceptable with fever, and what are things that we need to get on this?
Sure. I think, as you well know, fever has so much to do with how old the child is. We have different algorithms for a child under 28 days of life, a child over 28 days of life, a child who has certain vaccinations, who doesn't have certain vaccinations. And so I think a lot of it has to do with understanding those algorithms and communicating those as well as you can to the parent. Although you can imagine what a primary care visit is like. There's so much to go over that they're like, wait, what did she say? When do I need to worry about a fever? Also, what is a fever? I think that's still a big misconception. So still in 2026, a fever is anything over in Fahrenheit 100.4. There is some newer literature that does talk about that an elevated temperature could be different for another child. So we still do listen to the family if they're like, listen, they always run this, they're acting really sick and they're 100. But in general, when we're talking about medical algorithms, anything over 100.4, the biggest thing I think that families and providers should understand is that a child looks very different when they're actively febrile than when the fever comes down, because the fever is a curve. And so a child is 102.5 and they're going to be mottled and they're going to be breathing faster and their heart rate's going to be elevated. They might be listless. They might look really toxic. But when you get that fever down, the child perks up, they start drinking, their vital signs are stable. So the most important thing to me is get the temperature down. If you can't tell, is this a toxic kid or not? Because that's kind of our job in medicine, right? Is to determine like what level of illness is this? Is this something we need to intervene in right away? Or is this part of a normal infectious process? And that line is really hard for parents. And I still find it's hard for medical providers too, because you have another caveat where what do we also tell parents? Fever's normal, let it go. And then we're also like, treat the fever. So it's really confusing for families. And scared part coming is that, I started training when we had even more specific algorithms for fever. Like you had to do a CBC if the fever was over a certain amount, because, we used to have bacteremia in babies. And because we don't see that anymore, we care much less about fever than we used to. And so, and sadly, as vaccination rates are going down, we're going to start to see some of that bacteremia or bacteria in the bloodstream. And, we're all afraid we're going to miss it. So I think we're kind of in this like weird phase of being able to rest our laurels a little bit and say the fever is not that big of a deal, but then go, wait a minute, when is it? And are we going to miss that as medical providers? And is our advice going to be the correct one for that family in that time? So it's a big issue.
Yeah, it truly is, and like you said, I think still in 2026, there's still a lot of confusion that surrounds it, and again, not just for new parents, but also healthcare providers
Yes.
as to, how do we truly manage that? And so, when you talked about, is this kid toxic or not toxic? So for, an EMS provider that's showing up to a residence, what are some indications that this is that this kid is toxic or sick? Like, what are those red flags that they should be like, and is there an age group? So that'll be
Mhm.
like two-part. Is there
Yeah.
so and I can add to that shortly, but there's an age group where I tell EMS providers, like, if you get called to their residence, just transport them regardless, because there's so much that can happen in that
Mhm.
time frame.
Yeah.
Just you're better just get them into the system, get them evaluated, and rule those things out. But so I guess with that, is there a certain age group that you would recommend that if they are febrile, transport regardless? And then also those older than that, how do you separate out those typical
Sure.
fever to a toxic child?
I mean, what I would say definitely would be that 28 days and under. If we kind of joke that they burp the wrong way, they probably should be evaluated because they're so subtle. There probably are some better algorithms that you can educate me on if it's like the under the time of being vaccinated. So the first, 2 full months of life. We just don't have a lot of information about how well those kids are doing. As far as what to look for when you get there as toxic versus not, again, it's really difficult for EMS because they don't have the time to get that temperature down. But if the child has, if they're listless, if they're not, crying when you're examining them, if they're not, really fighting you when you're trying to examine them, kids will fight back. And they're angry, they're irritable, and they just want you to get off of them. If they're not doing that, that's a huge red flag for me. I don't like to see kids just laying there when I examine them. I'd rather that come in and be determined. Blood pressure is always like go back to blood pressure because if a child is febrile, they're going to look bad in some cases. And so again, the heart rate's going to be elevated, the respiratory rate's going to be elevated, they're going to be mottled. They might look more dehydrated or cardiovascularly compromised than they really are. But that blood pressure is going to be your biggest key to help you determine between the two. And so I always teach people to go back to get really comfortable with blood pressures in young children. And we struggle with it in primary care a lot, but it's so important.
Yeah, so that's one of the things that I hit on all the time is there's actual some of the EMT textbooks mention that, there's really no benefit to getting a blood pressure in a kid less than 8, and I'm like, "Who wrote that?"
No.
So,
Hmm.
I always stress it. I'm like, "Listen, we get blood pressures on 23, 24-week little
Hmm.
babies
Hmm.
within the first minutes of life."
Hmm.
You have to have the right equipment,
Yes.
and you also have to know the age appropriate norms. So I always teach the 70 plus 2 times their age for the absolute minimum. And I tell them for me, that's the only equation that I can take to
Yeah.
memory.
Yeah.
For me, we function in such a gray area, and I look at that as being a black line of if they are under that, they are decompensated. If they
Yes.
are above that, they are compensated or normal tensive. So it gives me a definitive cutoff. And then I think cap refill is another thing that EMS is really good at, and if they don't have the appropriate equipment or they're unable to get an accurate blood pressure,
Yeah.
I think cap refill is another good way of looking at that perfusion. And, you hit on the high heart rate, and I think that's huge in the fact of that is that first indicator, right? But I also think EMS providers look at pediatric patients and infants as, well, they have high heart rates.
Mhm.
And oftentimes, there's that statement that kids compensate and compensate and compensate till they don't, and there's this imaginary cliff that they fall off of. And once they fall off that, it's hard to get them back. And while I do buy into that, I also say that what's happening is we're missing all those subtle things leading up to it.
Yes.
And those are the things that I think as EMS providers that we're not in tune with, that we're not really aware of. And you really hit on some of those other key factors of what are those nuanced things that we're also looking for in addition, because they could be normal tensive, right? Up until that point do they stop compensating. So we have to look at that big picture and not focus on one thing and wait until they are hypotensive. Because once they're at that point, we are behind the eight ball there.
Absolutely.
So uh trying to think if there was anything else with fever. Oh, so what about so that's right. So the hyperthermic uh baby. What about hypothermic baby? Does hypothermia play into that conversation at all in the little ones or
It does. I mean, I think we're careful how much we talk about the hypothermia with parents. They do know about it. I mean, we have them mention it, but there's just so much to ask them to also kind of understand, the it going low. We just say call us if the temperature is abnormal, either way or the other. But yeah, hypothermia is another really, concerning sign, and sometimes even more concerning than hyperthermia because it's the opposite response. I mean, the brain is supposed to increase the temperature to fight off the infection. That's what it's supposed to do. It's doing what it's trained to do. But when it does the opposite and it goes low, that again, that can be normal, but it can also be a really concerning sign that the infection is overwhelming the child. And so that lower temperature also is something that is a big red flag.
yeah, absolutely. Um, so we also talked about noisy breathing.
Mhm.
So let's dive into that a little bit. What are some of the causes of noisy breathing, and how do we separate out like what is just upper respiratory and what is more concerning?
Sure. So, I mean, we think about things like stridor is a big one where you can actually hear the air going in and it makes a high pitched sound. So, that's more of what we call like inspiratory. So, they're breathing in and there's a noise, and that's usually going to be above the vocal cords or right below to above that. And so, you think in that case, you think croup, you think foreign body, and an unvaccinated, you're thinking like epiglottitis or like a more significant bacterial tracheal infection. And also, the child could be born with an anatomical abnormality, and the normal cold is going to cause that to kind of close in. So, if you can hear your child making a high pitched sound with every breath they take, that is concerning. I mean, and sometimes they look great and they're not having any distress, but that is that sign that we want to prevent it from getting into distress. It's hard to tell that sometimes for parents between upper respiratory nasal congestion because they also breathe in through their nose, especially little babies. They actually want to breathe through their nose. If their nose is congested, they're going to make a high pitched noise as well. But I always say that one sounds really junky. It changes with position quite a bit. If you do some nasal saline or a steamy shower, you'll notice it improve. And so that one, we just try to help them kind of figure out the difference between the nose breathing and the mouth breathing. So that's kind of the biggest one. And when parents tell me I hear them wheezing, I'm like, you're probably not hearing wheezing because wheezing is more lower airway. But you're probably hearing that upper airway that's slightly swollen. And so I'm actually more concerned when the parents say, I can hear them wheezing because you really can't unless you have a stethoscope. I mean, maybe in severe cases, we've seen that, but most of the time, no.
So when we start differentiating out between those uh, upper airway obstruction, lower airway obstruction, right? So the stridor versus the like asthma. So which would you say that you see more often? And do you see one in certain age groups more than another?
Sure. I probably see stridor more so than lower airway wheezing. And, in general, stridor is going to be in younger children. And so it's more common in that child that's under the age of 2 because their airway is naturally slightly narrowed. And so when they get any kind of infection, it causes the tissues around the voice box or larynx area to just get a little bit more swollen. And so then every time they try to take a breath in, it's kind of collapsing on itself. And so you can see, croup or stridor symptoms certainly in any person, but it's so much more common under the age of 2. Wheezing can happen in any age group as well, but it's going to be a little bit more likely in an older child unless they have something like, RSV or a specific infection. Or if they're premature, you could see both, sadly.
Yeah. Now, I guess one question I have as far as like in the primary care office, so if a child comes in with that, what treatment modalities do you have available in the
Yeah,
office versus when are you calling to have that patient transferred, to the ER, from your office, or when are you comfortable allowing them to go by private vehicle, right? I
sure.
know that's kind of a loaded question, but
Yeah.
like what are I guess what can you do in the office and what would you call 911 for?
Sure. So, what we can do in the office, and this is true probably for most places, is that we can give inhaled and injectable or oral steroids. So, if a child needs like dexamethasone for stridor, or if they need a breathing treatment of Pulmicort, which is kind of a newer treatment guideline for croup, we can do those in the office. We do have epinephrine if we feel it's an allergic reaction. That's one thing we didn't mention about upper airway was allergic reaction. We have the ability to do nebulizer treatment, such as like the inhaled steroid, as well as albuterol. And then we also have duo nebs in our office as well. When we would send a child to the emergency room from the office would be if say the child is having that breathing difficulty and their vital signs are abnormal. Because, like we talked a little bit about earlier, like children compensate pretty well from a respiratory standpoint until they go down pretty quickly. And so, if you start to see during your intervention that the vital signs are worsening, that's a sign that you're having either some VQ mismatch in the lungs or there's something more going on in the upper airway. And that would lead me to stop my interventions and get them to an emergency room. As far as, I'll keep them for a few hours if I have to. If I'm able to kind of turn them around and they're getting better, we can just let them hang out. Because in primary care, like we really don't want to send patients to the emergency room. We want to try to keep them out of the emergency room if possible. In my previous clinic, we had a crash cart. I had a LMA. We had a lot of things that we could do. I don't have that where I am, and I'm kind of glad because I don't want to use it at this phase of my career. So we can't give things like IV fluids. It's just not reasonable. Those things expire, and if you don't do them very often, your staff is not really trained at doing them. We don't have continuous monitoring available, and so we can kind of start those basics, and then we kind of have to move them on. Right now I am right next door to my emergency room. And so while I have called rescue, it was mostly like if someone fell and couldn't get up and I didn't want to move them.
Yeah.
Otherwise, honestly, we would just grab the kid and run over. I know that's not what we're supposed to do, but I live in a small rural town. And honestly, I would rather just run the kid across the street. And so we have done that before. When I feel comfortable sending a child by car, like say I need to send them to the children's hospital, which is 30 minutes away, they have to have stable vitals. And I just feel as if they need another layer of care that I'm not able to provide or be monitored longer than I feel comfortable with. They have to have completely stable vitals. The roads have to be good. There has to be so many things in place in order for me to feel comfortable doing that. And I always call the emergency room and say, this is what I have. This is what's going
Yeah.
on. This is what I've done. And get their advice because they might say, we would prefer that you call rescue because of A, B, C, and D. So even as long as I've been doing this, I always get the advice of the emergency room because it changes. As you've seen, like those guidelines change all the time. And I'd rather be extra cautious than have something happen while a parent is driving to the emergency room.
Yeah. So a few takeaways there, I think, is one, if you're calling for an ambulance, then there's a reason. Like
Mhm.
you don't want to send kids to the ER. So I think sometimes as EMS providers, we get somewhat frustrated when we go to reoccurring places often.
Mhm.
And yeah, like nursing homes is one of those things that we end up in a lot. But I think urgent cares is another one, because patients will think that they're going to an ER and end up at an urgent care, and I don't
Mhm.
think, people really understand the capabilities or lack of that are, truly available at an urgent care and, even more so at a primary care office. So I think the takeaway there is if you're getting called to a pediatrician's office, like, there is a reason.
Yeah. Yeah.
That's not a typical ask
Mhm.
there.
It's not.
I
And we all see those cases. This has happened to me when I was an ER provider. I think it's so helpful to understand both sides because when I was an ER provider, I would get so frustrated when an ambulance would come in because, we have to stop everything when the ambulance comes in. It's a big deal. You stop treating the patients that you already have, and the kid comes in and looks fine, and there's nothing wrong. And, it was like, gosh, we scared the family, and, this was a big expense. It shut down what we were already doing. But now being on the primary care side, where, there's so much limited things I can do in an office. Kids change every 5 minutes. They look terrible. And then you put them in an ambulance and they're like, this is fun. And they perk up and they act different.
yeah.
I see it really differently. And so I think that's why it's so important to understand what the other person is doing and is capable of. And then I always see it too like, great, this was an easy EMS call for me. Great. You know,
Y
that
yeah.
we can do that in 5 minutes then. Fantastic. You did my job for me. Everything is easy. But it's hard to do that when you're in an environment and you're exhausted and there's patients that are waiting for hours and hours on end. And so I get both sides, which is why, I like to talk about it.
Yeah, so I was on someone else's live yesterday, like TikTok live, and like
Mhm.
I went on this probably 20-minute soapbox rant about that of you because I'm sure you've seen right now there's a lot of videos out there of EMS versus nursing home
Mm.
nurse where and I the thing for me is I'm very fortunate that I started out as an EMT basic doing interfacility transfers with a private ambulance company, and then I was a firefighter paramedic, and then I was a nurse, and then, I worked in PICU, I worked in ER, I worked in, surgical ICU, and then now flight nursing, but I got to see all the different worlds and, like, why things occur this way in this area and why the ICU is asking the ER these silly questions. It's like, I have no idea. I haven't seen, and then you get to the ICU and you're like, "Oh, that's why they're asking that question because it's pertinent to their environment and their world." And until you can bridge that gap and meet people where they're at and understand both sides of that, I think and that's what I told him. I was like, "I don't have the fix. I don't know how to fix that, but I wish that we could all just understand that everyone's trying to do the best they can with what they have available to them, and not everyone has the same resources."
Or the same level of training and the same
Yeah.
expertise. And, I know in the children's hospital I used to work at in Florida, we had a flex team. And the flex team was, a group of nurses that did PICU, ER, floor, EMS. And they were such a great resource because they understood every single aspect of the hospital. And they were like, okay, well, this is why they sent it to you like this. Like, this is where it comes from. And this is what we need to have ready for the ICU. This is when you call them down. This is when you don't. So I just think it really helps to have that understanding and expertise. And then also the next part of that is communication. Like, I'm really lucky where I am. We're in a really small area. I can pick up the phone and call the PICU attending and say, this is what I've got. And, when I used to admit patients to our small rural hospital, they would telemedicine with me and they're watching the kid breathing and we're talking about what can I do? What can I not? They're walking me through it. And so when that patient is transferred, like, we're all on the same page. And I can just say, I don't feel comfortable. I understand what you're saying, but I don't have that level of experience. I've reached my abilities. And so a lot of it just goes back to communication. Like, who's your team? Who do you need to talk to? And how can we bridge that gap between actually picking up the phone and calling each other so that we understand both sides?
Yeah, and so that was gonna be one of the other points I was gonna bring up is the ability to phone a friend, right? So EMS has the ability for online medical direction, so they can pick up the phone and call a doc and ask, for online medical direction, and I think there used to be a stigma about doing that, like, well, if you had to call, then you don't know your stuff or
Mhm.
you're not and I think in pediatrics, like, that is huge. I can't tell you when I worked when I was a peds neo transport nurse, we would triage all the transport calls
Mhm.
with the PICU doctor. So we were on all those calls, and I can't tell you how many adult ER attending physicians would just call in and be like, "Hey, like, this is what we have. What are your recommendations? Like, what dosing, what meds do you want?" And those PICU docs and ER attendings, the PEM attendings would much rather support you and
Mm.
give you that information. There's no gatekeeping there. It's how can we support you? And sometimes that's just a phone call of, "Yep, you're doing everything great. Keep up the good work." And sometimes it's, "Let's change that up and let's do go this route, and here's what I would recommend." So I think that ability is if you're ever in that situation that you need some guidance or direction or clarifying information, just pick up the phone, reach out and ask for help, and
Yeah.
it's okay to ask for help.
It is, and I think the longer, you and I have been doing this for a while, and the longer that we do it, the more comfortable we get asking questions. Like, I am so much more comfortable at almost 50 saying, "I don't know the answer to this question, and this is, I haven't done this long, in a long time. I need extra help." And I was really, less comfortable with that when I first got out of training because you do feel like you're supposed to know everything, and it's that Dunning-Kruger effect. The more the more you know what you don't know. And
Exactly.
I'm so much more comfortable saying, Not my wheelhouse, not what
Yeah.
is what I know." And I think it's such a great humility to have as medical providers because ultimately, if we have that humility, then our patients get better care, which is all that really matters. It doesn't really matter what your ego says or not. Like, what is the best way to get care? And that's involving every aspect and working together. And I think most of us feel that way.
Yeah, I mention that a lot about and we'll talk about that more when we get to family-centered care here, but, having family present and how it evidence supports it,
Hmm.
and, but sometimes it makes us as providers feel uncomfortable, and that's what I always share with them. I was like, "But in that moment, it's not about our comfort level. It's about that patient and their moment in providing them the best care that we can, and that often is including their family in that."
Yeah.
So
Have you seen the memes where they have the person's in the ER and they're like, "My doctor's looking up something," and they can see them looking it up and they're like, "This makes
yeah.
me nervous." And all the medical providers jump in and go, "No, that's the sign of a really great provider." That they're like, "Hey, I don't know. Let me look this up." And I'm willing to put myself out there to learn something that maybe I didn't know before. And I actually started a little series on my social media about what are the things that I looked up this week
Oh, I
because
like that.
it was I loved it because I do look up stuff every single day and I think it helps parents understand, and I'll say, "Hey, let's look that up together," because I don't know the answer to that question. And I think that sometimes that may be like, "Well, why does she not know the answer?" But if you have a good relationship with them, they're like, "Wow, she's actually taking the time to look up something to make sure that my child gets the best care." So I think we need to get more comfortable saying, "I don't know. Let me look it up and phone a friend."
Yeah,
But it's hard.
absolutely. I love that. So, I'm gonna backtrack a little bit, and, there's 2 more, diagnoses or concerning things that I wanna talk about. So one was you had mentioned change in appetite, eating, and drinking. So what are some of those indicators and concerns and non-concerns surrounding
Sure.
that?
So the non concerns are that when a child has an infection, they will often not want to eat. And that is not as concerning as parents think it is. Because when your body is busy fighting infection, especially a child, they are using every tool in their toolbox and they don't need to waste time on digestion of food. So the body's really smart and it will suppress the appetite and even make the child feel like slightly nauseated at the idea. So if your child is refusing food, unless their throat is just so sore that they can't eat, that's a different thing. But if they just don't have an appetite, that is a lot less concerning for me, especially in the first 2 to 3 days. And don't push it because their body is trying to tell you, like, I need to take my energy to do all these other inflammatory processes, not to actually digest food. Um, however, drinking is very different. And so the body will actually increase the thirst when it's fighting infection. And so in a child who's compensating really well, they're going to drink a lot more than normal and have kind of increased urine output to try to compensate. So when they're not drinking, I'm a lot more concerned because dehydration can happen really quickly, especially in a child that's febrile and that child under 2. They just don't have as much reserve and dehydration can be sneaky. And so that's the one I care more about, especially if vomiting and diarrhea are on board. So they're losing it from fever, they're losing it from vomiting and diarrhea. And diarrhea is the really sneaky one because they're not going to look as dehydrated as they are. You know, those vital signs are not going to show you. The capillary refill may not be as bad. So you have to have your ears perked for a child who has severe diarrhea as well. But the eating one, I'm like, first few days, don't worry about that and don't panic over it, and don't push it. But the drinking is a really big deal.
Yeah, I that's one of the things I always, recommend is just push fluids, 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 like, make sure they always have a sippy cup or cup of water or, always have a drink available, and, I don't know if this is, right or wrong, but, I often say, popsicles too,
Mhm.
right? Popsicles are clear
Yeah,
f liquids, so,
yeah.
if they're not feeling well, then all the
Whatever you can
popsicles
get
they
in
want,
them.
a
Yeah,
as
I
many
don't
as
care. The only
yeah.
time we care about what you're giving them to drink, is in diarrhea, and that's because they need something like an electrolyte solution. But if they're not having diarrhea and they're just ill and I mean, I don't care, whatever. There was the old adage like, "Don't give your children milk when they're sick," and that's not true either. If that's what they will drink, then you want to push whatever you can get in them. Popsicles are appropriate. I really don't care.
Yeah. Yeah, just fluids, fluids, fluids.
Mhm.
Yeah. So the other one that I don't think we discussed, but I think that EMS sees a fair amount of and is still alarming is seizures.
Yeah, that's a good one.
So,
Mhm.
what are some of the initial concerns with seizures, and what do seizures look like in the little ones, versus in the adult, the full tonic-clonic, very obvious seizing? What are some of those low, um, you know, low-hanging things or the things that you see less often or
Mhm.
less clearly a seizure?
I think the first one to remember is that children have febrile seizures and adults typically do not. So if you're not used to the pediatric population, you're going to be overly concerned about a seizure associated with a fever. So children between the ages of 10 months and 6 years, but 4 is a decent cutoff as well. When they have a fever, it lowers their brain's threshold for a seizure. And I always think of it like you got like a lid on a pot of boiling water, and the fever is that lid. When you lift it off, it's going to boil over. And so children can have at their first time seizure, and it can be a true tonic clonic, complete generalized convulsion. They have all the signs and symptoms of a seizure. They usually only last for, 30 seconds to 2 minutes. And then EMS gets there and they have their first fever. So the first thing I always want to tell anyone that's working in emergency care is double check that temperature because that's going to make you feel a lot more comfortable. Because in general, if the child is back to their baseline and is acting typical and looks well, that is a lot less concerning than if a child doesn't have a fever. So febrile seizures, while scary, they are common in children and they are not usually associated with any other medical condition. How can you tell the difference? You can't. They should go in because you really need to monitor them and do a full physical examination. It can take 30 minutes after a seizure for a child to come back around and act completely like themselves. And that's going to need to happen in a more emergency environment. So even if you're like, oh, there's a fever, they should go in. Um, Sometimes a parent will tell you that, hey, they have a history of febrile seizures and the child is completely back to baseline. And there are some protocols, I think, where you don't have to take the child in, but that's more uncommon than the first time, just get them evaluated. In general, children can have very different kinds of seizures. You were kind of alluding to that. They can have just tensing episodes, they can have partial seizures, they can have staring episodes. And so it's a little bit more subtle sometimes in children, and they can't tell us what's going on. So there's not like an aura beforehand, and they're very fussy afterwards, and they can be fussy anytime. So I think it's really just more of any seizure activity in a child. And just go ahead and take them in. There's no reason to have to, deal with that any other way, but it helps to kind of get that temperature because that's going to reassure you more so than not. Any other specific questions you had about that? I kind of went off on the febrile seizure.
No, that's
Hmm.
perfect. It was just some of those subtle signs uh, of seizures and what that may look like. And I think one of the things for us as EMS providers is understanding the difference between a febrile seizure and a true seizure in the treatment and management of that, but then also understanding that most protocols say that we don't treat a seizure
Hmm.
until it's greater than 5 minutes,
Yeah.
and that's tough to do sometimes.
Hmm.
I think watching that, and those are very scary to see, and understanding that most of them self-resolve within that 5 minutes, and if we give those medications, then we're somewhat extending that recovery period and process. So
Yeah.
I
And it
think
can
that's
lead
a
to more, like what you were alluding to, it can lead to more testing for the child because if the child goes into the emergency room and they've had, a benzodiazepine to help with seizure activity, they're going to be, more likely to be admitted, more likely to get a CAT scan, more likely to get blood work. And so there's going to be interventions that aren't necessary. But yeah, I mean, what do we always say in emergency care? A parent's 5 minutes is 5 seconds. Like it is feels like forever when a
yeah,
child is having a seizure. And so just having that frame of mind to understand that children do seize, they're usually not associated with any other significant issues, support them respiratory wise, and just kind of, understand that it can be normal and kind of take a deep breath because it is really hard to watch. If you've seen it, I can't imagine watching for straight 5 minutes. Thank goodness.
yeah,
Even that doesn't happen very often.
right.
Mhm,
Yeah, and I think the other part of that is communicating to the family, right?
mhm.
Of explaining to them what you're doing or why you're doing it, but also why you're not doing something.
Yes, yes.
And having that conversation, and that's a very difficult conversation to have in that moment. But the other one that just came to mind that if you could speak on briefly would be like Brewy or Alti,
Mhm.
and those
Yeah.
are things that
Mhm.
um, I think as we talked about, you touched base on earlier where they called 911, they looked a certain way, and by the time they get to you, they look
Mhm.
great.
Mhm.
And I think that happens with EMS a lot, and these turn into patient refusals.
Yeah.
But, by time EMS gets there, it resolves, and then
Mhm.
family's like, "Well, now I'm embarrassed," and EMS is like, "Well, you don't need to go." That's that group that I was talking about earlier about, they should be transported. If you get so I feel like if you get called out for a 6-month-old or less, and I've almost extended it to 1 and
Mhm.
less,
Mhm.
that if you get called out to that residence, uh, take whatever they said and transport them regardless, because there are things that need ruled out and evaluated. Because unfortunately, those are the ones that we find down in the crib the next morning, that and I tell him, I said, "I assure you that transporting that patient at 2 o'clock in the morning on your 8th run, the burden of that is way less than coming in on your next shift and the next crew being like, 'Hey, we went back out to that residence and that kid was unresponsive,'" right? Like,
Yeah. Yeah, that is one of the scariest things in pediatrics is those, I mean, they're not called apparent life-threatening events anymore, but
Yeah.
that's the bruit, right? But
Yeah.
I can't help it. I'm too old to change my terminology, but
Yeah.
that's the idea where the child looks as if they are needing to be resuscitated. So the parent goes in and the child is not breathing and their color has changed. And, sometimes they're limp. And then after a few seconds, they're acting fine again. And that is never normal. It's not. I mean, it's never normal. It's never something we accept. Do we always find a reason? No. But there is a much higher likelihood that that child is going to have another event. And some of those are cardiac arrhythmia, central apnea, things that you are not going to be able to tell that that child has just by doing a quick intervention. And so I completely agree that they need to be seen and monitored. We used to admit them for 24 hours when I first started practicing, and I know we don't anymore. But there's a huge part of me that is, I wonder what the data is on how many of those still have an issue. And it's scary. It's something that none of us want to see or hear. And whenever I have a parent tell me, I felt like I had to breathe in their face, I felt like I needed to do CPR of some kind, or they were unresponsive, that is never a normal thing for a child. Even if maybe the parents overreacted and it really wasn't that. Because some kids with reflux or they have, periodic breathing where they'll hold their breath for a minute and then they'll start breathing faster. But that is, I mean, I've never seen a parent feel like they needed to resuscitate a periodic breathing. They just mention it like, hey, by the way, is this a thing?
Yeah.
Um, and so if they called EMS for that, it's a big deal. Agree.
Yeah.
Hmm.
Yeah, and just transport that
Hmm.
patient
Yeah,
and get them, evaluated. So I truly appreciate how clearly you broke all those down, and what stands out to me is that so much of pediatric care isn't just about the physiology, it's about interpretation. It's about how parents perceive what they're seeing and how we communicate what we're seeing to them. And then how we align on what happens next, right? How do we collaborate with them? So let's shift gears here slightly. And for me in pediatrics, family centered care isn't optional, it's foundational. So, from your perspective, what does true family centered care look like in 2026? And how do we balance that reassurance, education, and safety without minimizing what a parent is feeling in that moment?
sure. I mean, I can remember back to the days where everything happened in a silo. You put in an IV and the parent was out of the room. Decisions were being made with the parents not in the room in emergency situations or even, other intense situations. And I am so glad that that has changed because parents can handle it. It's very paternalistic of us to say that like they are going to affect our ability to give good care, because it is the exact opposite. And I got to watch that when I did emergency medicine, where I got to watch that culture change and parents being in the room during resuscitations and during intubations, and also I don't do circumcisions anymore, but I used to. And there was a lot more of parents being in the room for circumcisions. They should be like, why are we not allowing the parent to be there? And maybe they need to sit down in a chair, maybe there's someone who might bagel out, maybe they don't want to be there and that's their choice, but we need to always make sure that they're seeing behind the curtain. And I try to use that, terminology as much as I can. So much so into like every aspect of pediatric medicine. I think where
Hmm.
things have been going wrong in the last decade is that we didn't catch up to that need fast enough. Parents are so much more educated about their child's health care and they want even more. They want to have medical decision making. They want to be in on it. They want to understand it and they want you to let them know down to like how you bill for things and why you're using the antibiotic that you are. Why aren't you using an antibiotic? What about febrile seizures? Like I go over like all the details about them because just saying, "Oh, it's no big deal. It's just a febrile seizure." No, they want to know every aspect
Yep.
and they should because the more they understand their child's health and health care, the better informed they are. And that's true informed consent for anything that's happening, the good, the bad, like every outcome. If the family was on board, they feel so much more comfortable. So I see it as a huge part of everything that I do. And there's very few times in primary care where that's not the case. You know, we do have some things that are, if a child is over 12 and seeks care for certain things, that I am bound by law to not communicate with families. But even that doesn't happen very often.
Yeah. I think I spent a large part of my career, what I would say, turfing the family. Of we didn't want the family to ride along. We didn't want them involved, and it came to a moment where, and I think maybe this was in the PICU when I started in the PICU, because when I transitioned, so I was a pediatric flight medic at the time and finished nursing school and went into the PICU. And one of my biggest fears was going from, dealing with a patient for only an hour to having them for 12 hours a day and sometimes multiple days, and the constant interaction with the family. And honestly, that turned into my favorite part of working in the ICU. I
Same.
loved the family engagement. I loved having that same patient over and over, that continuity of care. And I ended up having one kiddo, one of the sickest kids I've ever seen. I had them pretty much every shift that I worked for almost 4 months straight. And it got to the point that the family would call in and be like, "Oh, good, it's you today. We're going to stay home with the other kids a little bit longer and we'll be up a little bit later today." And like that was so rewarding that that family entrusted me enough to be like, "Yep, we know she's in good hands. We're gonna stay home and spend some time with the other kids, and we'll be up later." But, as you mentioned, having them in the room and even in resuscitation, and so as I'm traveling around to quite a few conferences and doing, my Reducing the Pucker Factor lecture, and part of that talks about, resuscitation and having family. The evidence supports it, but you have to assign someone to the family and, to be able to communicate to them and again, explain to them what you're doing, why you're doing it, and uh, being truthful with them. Just honest, open communication. And even if the outcome is not the desirable, having those real conversations with them, it builds trust with them. It helps them process that situation. But again, something you hit on is at least offering it to them. Not everyone's gonna want that, but some are, and those are moments that they can never get back, and, that's where I'm big on, like, when you're delivering a a baby, right? Like, there's no reason that you can't pull over and have dad in the back if he wants to be like, those are moments that they're never gonna get back, and we get invited into such intimate, raw situations, and it's just a Tuesday for us, but it is a major life event for these families, and we can truly have an impact.
Absolutely. I always tell this story. So my daughter is 20. So 20 years ago when she was born, the women's hospital was across the street from the children's hospital. And so if a child needed any testing or intervention, they had to ride in an ambulance across the street to go get testing. And so my daughter needed a CAT scan right after birth of her head. And my husband, who, he was like, well, I want to go with her. Like, she's been in the nursery. I've been with her the whole time. My wife can't be with her. I want to go with her. And they were like, well, you're not allowed to ride in the ambulance. Like, you're not, it's only allowed to be staff. And he refused and said, I'm going to be with her when you take her across the street. And he was the first parent that rode in that ambulance from the women's center to the hospital. And after that, they changed the rule and said that parents should be offered to go, because he could just hold her. Like, she didn't have to be strapped down. She didn't have to be like it. They felt like it went better because he was there. And I think about that all the time. Like, we want to be involved as parents in our children's healthcare, whether we're medical providers or not. And it everything is better when you explain things and you allow the parents to be a part of all decision making.
Yeah, and, so one of the stories I tell, this recently happened for me was, we got, called out to, fly a pediatric trauma patient from outside hospital to the regional pediatric trauma center. And it was a car versus scooter or e-bike type thing. And the patient deteriorated before we got there and ended up being intubated. And so when we get there, the family was not there yet. And so we're bedside, we're doing all the things, we're switching over and doing our assessments and getting ready to go. And they come in and they say, "Mom's in the hallway." So I finish up what I was doing. I look at my partner and I say, "I'm going to go talk to mom, and I'll be right back with her." So I go out and mom is standing in the hallway by herself. She's got that 10,000-yard stare where her brain is making up every possible story. And I did one of those. I walk up and I was like, "Hey, mom, my name's Christopher. I'm one of the nurses with the flight team." And instantly she locked in. Like she locked in and was reading, like reading my name badge and fully listening to every word I was saying. And I just explained what had happened, what she was going to see when she goes in the room, and what the next steps were. And so I take her in, she got to do hugs and kisses, and we very quickly left. The flight was uneventful. We drop her off at the trauma center and we're getting ready to leave. And I see mom standing outside the trauma bay by herself again. And so I walk up to her and, again, just very anxious. And I walk up to her and I say, "Hey, mom, like, this is the trauma bay. This is what it looks like. This, every single patient that comes into this room, I know this can be intimidating. There's a lot going on. They want to make sure that she's getting everything that she possibly needs and that they don't miss anything. And this is normal practice, right?" And I
Mhm.
said, "I've personally worked with a lot of people in that room. You guys are in great hands." And she gave me a big hug and we went on our way. And the next day I woke up and I'm doom scrolling as I do,
Mhm.
and my Facebook feed is just full of this patient. Here
Oh,
it was a close friend of a close friend, and when she read my name tag, she ended up reaching out to me and was like, "I knew that when things were once this calmed down a little bit, that I was going to find you." And we got to meet up, and got to meet the kid and do all that stuff. But what mom said to me, she goes, "You were the only person that talked to me. You were the only person that explained what was going on." She goes, "You brought calmness when I couldn't even breathe." And I was like, all I did was, I just explained to you what was going on, and that was
yep.
it." And
Yep.
that was the impact. Like, obviously, that will live with her, but her saying that to me will live with me forever, right? And I think more people need to understand that we get invited into those terrible situations, and the impact that we have is long lasting.
Huge. And this can be in every part of healthcare. And, if you see someone walking in the hallway and you work in the hospital and they look we know that look. Like everyone in healthcare knows that look. Stopping for a second and saying, "Where are you going? Do you need help getting there?" I mean, I've seen parents lost in the hospital trying to get to their kid and they don't know where to go. And it's so important to remember that, like you said, you're invited into sometimes the worst moment of these people's lives, and you can make it better or you can make it worse. And the only other thing I would add to that is, hospitals need to be listening to this because as you understaff hospitals and as you don't support healthcare workers, that's the first thing that's going to go. And that's one of the most important things we do. And if there's not enough of us, we're going to choose the patient care over the interaction with the family, and it's such a loss. And so they need to really be listening to this. Like they're not staffing correctly. There's not enough. So to give kudos to the nurses that are also out there trying to do that, we know that you have too many patients and too much on your plate. I have to move too fast in clinic. I cannot move. And so when you're waiting an hour for your doctor in clinic, and sometimes that's because they are giving sometimes the worst news. And in order for us to keep that humanity and do a good job, we have to get comfortable with letting other things go.
Yeah, absolutely. So one of the things that I do that kind of speaks to that is when I walk into, as a flight clinician, when I walk into a room to transfer a pediatric patient, one of the things that I do as soon as I walk in that room is I make eye contact with mom and dad, and I I introduce myself. I'm like, hey, I'm Christopher. I'm one of the nurses with the flight team. Right now, your child is my priority. What we're going to do, I'm going to go over, I'm going to do my assessment. We're going to do some things. We're going to get report from the staff here. But right now, your child is my priority. And after I do all that, I will circle back and we will have a more detailed conversation. Do you have any questions for me right now that affect any of that? And oftentimes, like you can see their whole demeanor shift of like, nope,
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 you go.
you do what you
Go.
need. Somebody
Mhm.
sees me, right? Somebody acknowledges me, and somebody is making my child a priority. Yep. And just that little bit of reassurance and support, like you can truly see the shift in those families when you do that.
Sure.
Yeah. So, well, Dr. Tyson, I really appreciated this
Oh,
conversation.
this
This
was
was
great.
phenomenal. What you helped do today is really help us narrow that space between that reassurance and escalation, and you've helped us define what's common. You've clarified what truly concerns you and what should concern us as providers. For any of my EMS and acute care listeners, this conversation is huge. It matters. We have to include families in the care that we're taking care of our patients. Um, so again, thank you so much for the work that you're doing in the clinic. Thank you for stepping into the digital space responsibly, and thank you for helping reduce the pucker factor today and not amplify it. I am truly very grateful that you joined us today and took the time to do this. And so, I guess with that, do you have any final parting thoughts or comments? And then also let people know where they can find you on the social media platforms.
Sure. No, thank you so much for having me. I really have enjoyed this conversation as well. And it helps kind of bring me back to also making sure that I am also reducing the pucker factor. So I appreciate it. No, you can find me on all forms of social media. Dr. Tracy VT on TikTok. I also am Dr. Tracy Tyson on Facebook and Instagram, as well as YouTube. And so find me on any of those platforms. I try to link them all together. I also do lives on TikTok just now. I'm obviously not giving medical advice, but it's just nice to be able to connect with families and see what are their concerns and to try to bridge the gap to see us as in medical providers as people that they can ask us questions. And so those are really fun as well. So if you ever see a live of mine, feel free to jump on. And even as medical providers, sometimes we talk about, medical school training and things like that as well. So hope to see you.
Yeah. Absolutely. So that's where we actually met, was in one of your lives.
Yes.
I had joined in and was just blown away by the uh, evidence-based information that was being provided and just the level of uh, patience and sincerity. And it was just it was a very comfortable space. So thank you for everything that you're doing, and keep up the great work.
Thank you for having me. You too.
Absolutely.
Yeah. The call goes out and the crew's on the move. Lights up, crew locked in, yeah, we know what to do. Their hearts beating fast in the back of the rig. But we don't panic, nah, we're dialed in big. Scenes chaotic, kids sick, but we're right on track. We breathe deep, lean in, bring the calm right back. We're reducing the pucker factor, turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop, yeah. We're the Victory content crew, showing what the pros can do. Turn the fear into calm under pressure. Pucker factor, gone forever. Pucker factor, gone forever. Yeah. Got skills, got data, got a plan that hits. Got the airway game strong and the trauma kids. Yeah, from scene to scene, we're raising the bar. EMS super nerds, yeah, that's who we are. Hey, hey. For the medics in the front line, let's go. For the flight teams on the lifeline, let's go. turning fear into confidence. From the med unit to the helicopter, bring the calm when the chaos won't stop. Yeah, we're the Blackery content crew, leading what the pros now do. Turning fear into calm under pressure. Pucker factor, gone forever. Hey, hey, yeah, 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 yeah. Oh! Yeah, yeah, yeah. Pucker factor, gone forever. Yeah. Gone forever.